Oh, it remains a very difficult issue. In fact, basically, the two studies are not similar. So, but otherwise,
the results are not similar. Or?
The results, the design, so the patient population and patient characteristics are not the same. So the IFM study was designed for patients with poor prognosis. So patients with high beta-2 microglobulin, patients with poor cytogenetics. So IFM design was something special, and Italian design was, I would say, more flexible. So, but okay, it's not only the question of French versus Italian, in fact. So the issue of allogeneic transplants remains something difficult, and it's all cooperative groups have to define what is a good indication for allogeneic transplant, and that's not so easy, in fact. So what I can tell you is that at the present time, in the IFM group, we consider that patients at the time of the first relapse who are chemosensitive patients with an adequate donor, these patients are eligible for allogeneic transplant. We also basically consider that patients at the time of diagnosis, but with a very poor prognosis, and we know, for example, that patients with deletion 17p, which is a very special cytogenetic abnormality, these patients have a poor prognosis. So we say, okay, patients with deletion 17p at the time of diagnosis, if these patients have a good donor as well, so they are eligible for allogeneic transplant frontline. But okay, these are the two main indications in the context of the IFM group at the present time. But honestly, I would say it's open to discussion. So that's what we consider a correct indication at the present time.
Would you think differently? Would you recommend your patients differently if they were younger or older, or many younger?
You know, with the emergence of non-myeloablative allogeneic transplant, patients can be a little bit older. Okay, we will say that if you are less than 60, possibly you can get some kind of allogeneic transplant.
You can't.
You can.
You can.
Yes, if you are in the setting we presented before, that's not only a question of age. I think it's more a question of prognosis and donor and basically indication, but not only a question of age.
Okay. In which stage will you recommend it? Which stage of the disease?
So, as I said before, we consider two main possibilities. One of them is frontline with very poor prognosis, especially deletion 17p, and I would say second line at the time of the first relapse. If this patient is still sensitive to chemotherapy, if this is a young patient or relatively young patient. You know, for example, if you have a 50-year-old patient at the time of diagnosis and you have a relapse after 2 years, so he or she is now 52, and she received frontline something like VTD or VRD, a single transplant, sometimes some VTD or even VRD consolidation, sometimes maintenance. If you have relapse after a couple of years, and if this patient is still sensitive to something, and if a donor is available, that's a nice. I think we usually say that it's probably the good time for that, because after you will have a second relapse, third relapse, etc., and so the patient will be refractory to the majority of agents, and so first chemosensitive relapse with a good donor is fine. Frontline is more. I would say frontline is much more challenging. And in the frontline setting, in your opinion, there are very few indications, in fact. Only patients with a very poor prognosis can receive allogeneic transplant frontline.
Frontline.
No, I would say that in the frontline setting, for example, I am the PI of a very large trial looking at lenalidomide and low-dose dex frontline. This is the IFM 2007-01 study, which is also named MMO20 for Celgene. This is the same study. This is a huge study. This is 1,600 patients frontline, elderly patients. And at the present time, we have enrolled 1,400. So the study will be closed for enrollment at the end of this year. And we have used lenalidomide low-dose dex. So lenalidomide or low-dose dex frontline for elderly patients. I can tell you that that's very well tolerated. That's well tolerated. That's safe, no problem. So I would say.
What about neuropathy?
Excuse me.
Neuropathy.
Oh, there is no neuropathy, virtually no neuropathy. So lenalidomide is very safe in terms of neurotoxicity. So the incidence of severe neuropathy with lenalidomide is only, I would say, 1-2%, not similar to dexamethasone alone, in fact. So it's safe for neuropathy, and it's safe in general. The relapse setting is something different, because in the relapse setting, the Lendex has been approved in the relapse setting based on MMO9 and MMO10. MMO10 was also conducted in Israel, and at that time it was high-dose dex, so conventional dex. So 40 milligrams daily, days 1 to 4, 9 to 12, 17 to 20 for the first 4 cycles. But that's an important amount of dexamethasone. Currently, at the present time, we have moved, for the majority of the patients, we have moved from the high-dose dex to the low-dose dex, also in the relapse setting. But it's okay, this is for the majority of the patients. It's not so clear-cut, because you could say also that in the relapse setting, some patients still need high-dose dexamethasone. For example, if you have a very aggressive relapse, very fulminant relapse, you could say it's more manageable in the context of high-dose dex than in the context of low-dose dex.
So high-dose will be 40 milligram?
High-dose will be 40 milligram and the usual schedule used in the past. So that will be 40 milligrams day 1 to 4, 9 to 12, 17 to 20. But this could be only one cycle, for example, just to lower the tumor burden. I would say in the frontline setting, go to low-dose dex. In the relapse setting, I think that some patients still need high-dose dex. The majority of the patients are fine with low-dose dex, but some patients could need high-dose dex in relapse. Okay.
And what do you think about allogeneic bone marrow transplant and its role in the future of the myeloma patients?
That's your first question, basically. So this is allogeneic. Yes. I think it depends what is the future. If the future is in the future we may be able to cure some myeloma patients without any allogeneic transplant, in fact, because that would be fine.
Yeah. So the last one.
In this decade, between 2010 and 2020, that would be fine. I will be retired in 2025, so I hope we will be able to cure myeloma before that time. But the answer is probably yes. We had a meeting in France last Saturday with Dr. Balogi from the US, and he says that obviously it's open to discussion, but he says that if you look at low-risk patients in the context of his total therapy program, he says that probably 50 to 60% of patients are cured.
Cured?
Cured. Yes. Okay. You could say okay. It's very optimistic, but even if you say it's not 50%, if you say it's possibly something between 20 and 30%, I'm convinced that at the present time, some patients with myeloma are very probably cured, in fact. Because if you use, for example, if all novel agents are available, if you use VRD induction, a single or even a double transplant, VRD consolidation, lenalidomide maintenance, and this kind of approach in a low-risk patient will possibly achieve cure, in fact.
So you believe in a long-term maintenance with lenalidomide?
I believe in maintenance, long-term maintenance. So that's a very good question, because as you know, lenalidomide, we have basically 3 maintenance studies. One has been conducted in elderly patients. This is MMO15 from Celgene. Dr. Palumbo is the PI of that study, and we have 2 studies in the transplant setting. One is IFM, and one is CALGB in the US. And as you know, possibly both transplant studies have been presented at ASCO last year and this year, and will be presented at ASH next December. And the results are very concordant, so very consistent, very concordant. It's the same feature in elderly patients and in the transplant setting. So there is a huge benefit in terms of progression-free survival. There is no survival difference yet. We don't know that. The survival is high and similar between placebo and lenalidomide. But anyway, the PFS benefit is huge. So we may expect some survival benefit. So that's good. That's good for lenalidomide maintenance. There is another question behind that. Say, do we need maintenance until progressive disease, or would it be acceptable to have 1 year maintenance or a couple of years maintenance? That will be an open question. But okay, what we can say is that based on CALGB, IFM, MMO15 from Celgene, there is a lot of evidence that lenalidomide maintenance will be approved.
In Europe, is it approved as a maintenance?
It's not approved yet, no. But that may be the case in the future. As you may have 2 possible approvals, in fact. One option is lenalidomide will be approved frontline from diagnosis to maintenance. So that's a kind of global approval. So you say, okay, you can give lenalidomide from diagnosis to maintenance. Another
together with the dexamethasone.
Together without. In the maintenance, this is without dexamethasone. But this is a global frontline approval for lenalidomide. In some countries, you could say this will not be a global approval. This will be a maintenance approval. So the drug will be approved after transplant or in elderly patients after a kind of conventional induction used in elderly patients. So that's 2 possible options. That's not the job of IFM or investigators. That's the job of health authorities, and they will have to decide about that.